Not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's On Call, hashtag She's On Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon in New York City and in Wayne, New Jersey. My co-host, Dr. Marina Kurian, is a minimally invasive surgeon and bariatric surgeon, and unfortunately is not with us today, so you guys are stuck with just me. We have an amazing show. Thank you for tuning in on time. Most, but not all of America turned their clocks backwards today, so some of us got an extra hour of sleep, and those of us who worked overnights or the weekend unfortunately got to work an extra hour. So shout out to our friends in healthcare who had to work an extra hour this weekend. Thank you. You know, it's November, but it's also sometimes called Movember. A lot of men don't shave in Movember to raise awareness for men's health issues and prostate cancer in particular. Today, we're going to devote our show to prostate cancer and men's sexual health. And we will be meeting Dr. Ashley Winter, who is a urologist at Kaiser Permanente in Portland, Oregon, and who is an editor at the Sexual Medicine Reviews, and Dr. Sophia Kamran, radiation oncologist at Massachusetts General Hospital and assistant professor at Harvard Medical School in Boston, Massachusetts. So please like and share and tag your friends who might be interested in meeting these amazing physicians and learning about this very important health topic. You know, as we said on the breast cancer show last month, breast cancer doesn't just affect women, it affects the entire family, the entire community, and we can say the same thing about prostate cancer, not just being something that only men should be interested in, but in fact, as a community, we should know about. So we are live on Facebook, on YouTube, on Twitter. Please chime in, let us know where you're watching from. Don't hesitate to ask questions of our guests. They really know a lot of stuff. We are carried on WBAI 99.5 FM in New York and WBAI.org on Mondays from 2 to 3 p.m. Eastern Time. And we have a podcast that we're very proud of. So you can listen to these shows anytime you like. So let's start with some news of the week. So in emerging from COVID news, the New York City Marathon is back. It was a chilly and sunny 40 degrees or Fahrenheit or 4 degrees centigrade at the start of the marathon. It's all the way up to 50 or 10 degrees now. Dr. Lippy Roy, who is a friend of She's On Call, is one of the army of medical personnel volunteering their time and effort for these over 31,000 runners who are running today. So good luck to all of the runners. And I want to just do a personal shout out to 3 of them. Elizabeth Ann Tomasi, who along with band director Dr. Darren Gage, led the Glenridge High School Marching Band to #1 place in national championships at MetLife Stadium yesterday, is running the marathon today. She is bib number 22035. So go Lizanne. Kelly Garvey Sachter is winning against multiple sclerosis every single day, and she is running wearing bib number 32485 to support the Tisch Multiple Sclerosis Research Center of New York. So go Kelly. And the niece of one of my medical assistants, Dana Gallo, is running her 3rd marathon today to raise funds for Human Rights Campaign. Go Dana. Well, on the COVID front, we have some bad news, some okay news, and actually some good news. We hit some really heartbreaking milestones this past week. Worldwide, over 5 million people are known to have died of COVID-19, and that is very likely an underestimation. There are nearly 250 million reported cases of COVID, and nearly 200,000 people died of COVID-19 just in the past 4 weeks. Only 39% of the world is fully vaccinated, with many countries below the 10% level. And unfortunately, Europe is facing a harrowing fourth surge right now. In the US, our numbers are nearly 750,000 deaths and nearly 46 million total cases of COVID-19 since it began over a year and a half ago. This is not over. We still have about 19,000 new cases per day and 1,400 deaths per day of this disease. We have some major hotspots in the Midwest and in Alaska, and there are still hospitals that are just overrun and unable to care for other patients, like people who have heart attacks or strokes or get into accidents. The okay news is that about 2/3 of people aged 12 and older in the US are fully vaccinated, and those who qualify are getting boosters. Why should you get vaccinated? You are 6 times more likely to get COVID if you're not vaccinated, and you are 12 times more likely to die of COVID if you're not vaccinated. So please get vaccinated. We saw some huge positive news on the COVID front this week. The CDC, after hearing from the FDA and the review board, the CDC, or the Centers for Disease Control in the United States, voted unanimously 14-0 to approve the COVID-19 vaccine for children between 5 and 11, which is wonderful. The vaccine is made by Pfizer, and it contains 1/3 of the dose of the adult vaccine. It even contains a tinier needle than the adult vaccine, which already has a tiny needle. It is a 2-dose vaccine, so your child has to come back in 3 weeks to get their second shot, but this is a great benefit. Why? What happens when we vaccinate these younger children? For every 1 million vaccines we give to the 28 million kids in the US between the ages of 5 and 11, we prevent 114,000 cases of COVID. We prevent 191 hospitalizations in girls and 226 in boys. We prevent 260 cases of multiple inflammatory syndrome in children. And we prevent 60 girls and 72 boys from having to enter the intensive care unit. But by vaccinating kids, we don't just protect kids. The research is very clear that by vaccinating kids, we actually protect adults and the entire community. So there've been some really cool modeling that's been done. And the projections show that vaccinating younger children, as we have now started to do, protects the whole community from both the Delta variant and from future variants that may appear. And then in our final good news of COVID story this week, there is an oral treatment that has been approved in the United Kingdom for COVID. So this does not replace vaccination. This is like getting a flu shot, but then if you get the flu, you can take a pill called Tamiflu. So this is, you get the vaccine, please, because it really protects us all. But if you get the disease, the Merck product, which was approved in the United Kingdom, cuts your risk of serious or severe disease by half if given within 5 days of onset of your COVID disease. And then there's another one that Pfizer just presented their data to the United States Food and Drug Administration, and it's a drug we know. It's a drug called ritonavir, which is used in HIV treatment. And in people at risk for serious or severe disease, it actually cuts their rate of hospitalization or death by 89% in the initial trials. So again, this does not mean don't take the vaccine. Please take the vaccine. But this means that if you get a breakthrough infection, we now will be developing treatments to help us, because we now think that we are going to be living with COVID in some shape or form as we live with the flu. So now that my soliloquy is done, I'm reminding you all that we are live on Facebook, on YouTube, on Twitter, on Sri Srinivasan's LinkedIn page. We are very, very excited to meet our guests. We have two experts in prostate cancer and in men's health. We have Dr. Ashley Winter, who is a urologist at Kaiser Permanente in Portland, Oregon, who is an editor at Sexual Medicine Reviews, and Dr. Sophia Kamran, who is a radiation oncologist at Massachusetts General Hospital and assistant professor at Harvard Medical School in Boston, Massachusetts. Welcome to She's on Call.
Hi, great to be here.
Hi, we're very excited. Yeah. Thank you.
I'm so happy to meet you. And I know Marina is really sad not to meet you today, but hopefully as the world opens, we will actually get a chance to meet each other in real life and not just through video screens. So Sophia, you pointed out that it's Marie Curie's birthday. Marie Curie has been my hero since I was a little girl. I had a skirt with deep pockets in it, and I felt like I was in the lab doing experiments and discovering radiation and radium and polonium, like Professor Curie. So we will actually talk about what her discovery has done to help humankind. It's pretty extraordinary. As you know, she won many Nobel Prizes, and she actually was offered a lot of money. She was offered $1 million back in the day to sell radium. And she said, nope, this is for the world. This is something I discovered, and it's for the world. And it's quite an extraordinary story. Let's get underway and talk about prostate cancer. So prostate cancer is really common. It's the most common cancer after skin cancer in men, fourth most common cancer worldwide. But as you guys pointed out earlier to me, more than 98% of men diagnosed with prostate cancer will live at least 10 years. So we really have to think about what treatments will do for their quality of life. So maybe we can talk, Ashley, there's all sorts of data, whether it's 1 in 6, 1 in 7, 1 in 8 men. Can you give us a sense of the scope of this problem?
Yeah, I mean, it's definitely super common. You know, as a urologist, it's one of the most, men coming in for prostate cancer screening diagnosis is absolutely one of the most, common things we see. It is interesting actually. So if you'll remember, maybe about 10 years or so ago, the United States Preventative Services Task Force, which puts out recommendations for screening for various cancers, had recommended against prostate cancer, like PSA screening, routinely. And then they eventually, changed it to a shared decision-making conversation with your physician. And that did initially actually lead to a decrease in men coming in for that. Diagnosis and evaluation. I think the pendulum's swinging back now to realize it's super important to get men evaluated for this, because actually in the years following, that change in guidelines, there has been an increase in men presenting with advanced disease, meaning cancer spread outside of their prostate gland. And that is unfortunate, because it is something that, if it's caught early, can oftentimes be cured or very effectively treated. And so, yeah.
So I think that's really very important, because, we talked on the breast cancer show about the guidelines now say women don't really have to do breast self-exams. Men can't really do prostate self-exams anyway.
No, this is like a huge peeve of mine. So, okay. Even without take out the whole discussion of whether men should be getting PSA testing done, I think that there's been a really precipitous drop in people doing prostate exams, which is essentially done through a rectal exam, right? And a lot of patients tell me that their, screening test or their annual physical, they're not having a prostate exam done anymore. And I think there's this kind of misconception that if we're respecting our patients' bodies, that we're not doing invasive physical exam. But part of a comprehensive evaluation of health is respecting your body. And some people say, oh, well, we have this blood test, we don't need to do a prostate exam. But there 100% are men who have a normal PSA. So PSA, sorry, I didn't explain that enough. A PSA is the most common blood test to screen for prostate cancer. but it doesn't always correlate with prostate cancer, and I know you'll get into that. But essentially, there are people who, when you examine them, their prostate feels like a rock, and they have prostate cancer even though they have a normal PSA. And so, a rectal exam is really simple. There's almost no risk associated with it. Oftentimes, it's not going to add additional benefit, but it can add additional benefit. And I just really wish people would go in and ask their doctor to do a prostate exam on them.
Yeah, I think there are different risks for developing prostate cancer, and you can see that this graphic sort of lists overall. It's higher when we get older, if we have a family history, genetic factors. Unfortunately, Black men have a 75% higher risk of getting prostate cancer than do white men, and they have a 2.2 times risk of actually dying from their prostate cancer, which, we talked about is kind of a curable cancer if you find it early enough. Can we talk about these other things? Like, what are these myths of things that cause prostate cancer? And maybe what are lifestyle modifications that men can do to reduce their risk? Ashley?
Yeah, I think most of the misunderstanding, I mean, you put up something there about ejaculating or not ejaculating. I mean, there is actually a study that was fairly well done looking at ejaculating and prostate cancer risk. And they showed that if you're ejaculating, I think more than 21 times a month, that you have a slightly lower risk of prostate cancer. And it seemed to be good data, but the question is, I mean, what's the value, right? I mean, the incremental change in risk was very minimal, and I really don't like promoting those sort of ideas to patients, because do they need to have a panic attack that they're not ejaculating every day? I mean, that's kind of ridiculous, and I don't. I mean, far and away the most meaningful way of reducing prostate cancer death is by doing appropriate screening and testing. I think it is really important to highlight, the genetics, which you're talking about. That is a real influence, and it's something that in the recent years has been much more of a focus. So a big area that's really exploding in terms of research and understanding is the role of, for example, the BRCA mutations. So the BRCA genes, which are typically spoken about with breast cancer, and there is a link between the BRCA mutations and prostate cancer. So, it is something you can talk to your patients. A, do you have a family history of prostate cancer? But B, do you have a family history of breast cancer? And particularly, BRCA related breast cancers in your family. And that can prompt, a change in the way you screen or follow the patient.
That's really interesting. Thank you. We have people watching from all over the place. Miriam Berkeley is watching from Manhattan and got her Moderna booster. Congratulations, Miriam. Sucharita Iyengar is watching from Delaware. Jacqueline Alvarado Medina is watching from Atlanta. Meghna Vishwanath is watching from New Jersey. Divya Krishnaswamy is watching from Chicago area. Rie Bronander is watching from New Jersey. Tracy Burnett is watching from South Carolina, North Carolina, one of the Carolinas. I have a real problem with anything outside of Manhattan. Jack Berichick and Bernard West are watching. Nicholas Chin is watching. Trisha Toriano is watching. Thank you guys so much. I think this is so important. I've already learned something that I didn't know about the BRCA gene and prostate cancer. Sophia, I know that you're not doing the examinations, and we're going to talk about the examinations. Can you talk to us a bit about what prostate-specific antigen, or PSA, measures, and how you might look at it from a radiation oncologist perspective?
Yeah, absolutely. And I just want to also emphasize what Dr. Winter said. We actually really emphasize the prostate examination too. So whenever a patient comes to us with a diagnosis of prostate cancer, we examine with the DRE. And then after treatment, especially as a radiation oncologist, it's really critical to continue doing the DREs, even when the patient says, hey, I was treated already, you radiated my prostate. And I say, no, we are going to come in. I need to see you. I need to do the rectal exam. So anyway, that's something that we find to be important.
Means digital rectal exam.
Yes, the digital rectal exam. Yeah. Yes, to feel the prostate. And yes, so with regards to the PSA, so as Dr. Winter explained, it's the prostate specific antigen. So that's a test that we can measure in the blood. And just to emphasize, it has been controversial, as Dr. Winter explained earlier, because it's made by the normal healthy prostate, but it is also made by prostate cancer cells. And so men have, just as everyone is different, men have different anatomical variants of the prostate. You know, some men just naturally have a larger prostate, some men have a smaller prostate. And so whenever the PSA is measured, we cannot tell if it's, you know, if it's high just because it's a natural, you know, phenomenon to that person, that's just what they naturally are, or if it's high because there's cancer cells. And that's why it's been a very controversial test before they're diagnosed with prostate cancer. Now, I do want to emphasize it's extremely important to follow the PSA, and it becomes an excellent biomarker after treatment of the prostate cancer with either surgery or radiation. But beforehand, it's very controversial.
The other thing, just to interject, is there are specific activities that can raise the PSA level. And, you know, I think in your diagram, it may have indicated that, but I tell all men before they do a PSA test, particularly in the screening phase, to make sure to not ejaculate or do bike riding or anything that puts really significant pressure on the area where the prostate is. So basically that area between the back of the scrotum and the anus, because that actually can really significantly increase it. And I've had men that come to me because they had a high PSA, and you know, when they had their annual testing done. And I say, well, I always repeat it. Like I always do a second one before we schedule something like a biopsy, which is invasive. And I say, make sure you don't ejaculate, you know, or bike ride, et cetera, for 48 hours. And sometimes it comes back perfectly normal. So, you know, and they had a real scare. So I think for all the, you know, men out there listening to this, and anybody who has, you know, someone in their life that they love and care for, who's a man who's, you know, undergoing screening, is to say, hey, I'm going to avoid those activities before I have my annual PSA screening, because it can improve, you know, the value of the test.
So are there symptoms that people should look for? You know, there's prostatitis, which is inflammation of the prostate. There's benign prostatic hypertrophy, which is benign, not cancer, increase in size of the prostate that can cause some symptoms. And then there's prostate cancer. So can you talk to us, Ashley, a little bit about what the symptoms are that people should look out for to report to their physician or to seek some medical care?
Yeah, that's a great question. So the vast majority of prostate cancer does not present with any symptoms at all. There are advanced cases where there are, for example, difficulty urinating because the cancer's, you know, pushing on the urethra. You know, there are advanced cases where there's back pain, weight loss, blood in the urine. But the vast majority of men who have difficulty urinating, straining to urinate, getting up many times a night, just have what's called benign prostatic hypertrophy, which is what you were saying, BPH. And that's because most of the time, the primary focus of prostate cancer is in the peripheral part of the prostate gland, and actually the part that's up against the rectum. So that's why our rectal exams are good for prostate cancer, you know, screening. But the part of the prostate gland that surrounds the urethra and can lead to urinary symptoms is usually less affected by prostate cancer. Now, it's not always the case, and certainly you can have prostate cancer in all parts of the gland, but most of the cases of urinary symptoms related to prostate is just age-dependent prostate enlargement. And it's not it's a normal part of aging, right? So the hormones associated with aging make the prostate bigger. I say it's the same hormones that's responsible for male pattern balding, actually. So, you know, it just happens. So, you know, those symptoms should be treated if it's bothersome to you, but it shouldn't make you fearful that you have prostate cancer. I think, honestly, the most important thing for screening for prostate cancer is just physical exam and blood work.
So, you know, we just had a little graphic up there that I'll ask our producers to put up again that just shows what is the most typical presentation of prostate cancer early, which is in the back part of the prostate gland, which is just in front of the rectum. And the prostate gland itself surrounds the urethra, which is the tube that goes to the end of the penis. So can you talk to us about how often you are finding these early prostate cancers? And I know we talked a little bit about the DRE, or the digital rectal exam, but how important is it, and how accurate is it when you do that exam? Maybe I'll talk to Ashley about that.
Yeah, I mean, it's so prostate exam, there are many people with prostate cancer that have a normal prostate exam. So it's not a very accurate test at all. And the main reason I'm an advocate for it is because you can catch cancers on it, particularly when other tests are negative, and it's of minimal cost and minimal risk, right? Aside from the discomfort of having, a finger up your butt. But so there are plenty of people. I mean, a really common category of cancer that we have as a category is a prostate cancer detected based on PSA and with a normal exam, and that's kind of like a category, and that is the majority of people who do come with localized prostate cancer.
Mm-hmm. I would just like to say that I find it very useful when a gentleman does have an enlarged prostate and their PSA it just tends to be on the higher side. Then if you do feel something abnormal, and if you know that they already have a larger prostate and that's producing their PSA, you can pick up on something and just say, okay, we need to investigate further.
So I think it's really important when you're talking about the need for not just the blood test, but the need for actually an educated examiner to examine, looking for the right thing. And I appreciate what you said earlier about, avoid things that are artificially elevate your PSA, so you don't go down some crazy path of medical workup because you decide to go for a 10-mile bike ride the day of your PSA test, right? So once there's a tumor there, then, or you suspect that there's a tumor there, you have to biopsy it, right? So how are these biopsies done, Ashley?
So there's two main ways. The historic way that most of these biopsies were done was through a rectal ultrasound probe. So basically the patient comes in, we put an ultrasound probe in your rectum, and then we do a template of samples, usually 12, just, based on quadrants that we have kind of made up. We give antibiotics and some numbing medicine, and people do great. I mean, very minimal pain. There is a small but significant risk, like less than 1%, but of a severe infection after that type. So definitely a very new trend that is gaining a lot of popularity is to do what we call a transperineal biopsy, which is basically where the probe is put on the skin, again, that I mentioned before, between the back of the scrotum and the anus, and you actually access the prostate that way. And then another really important innovation in prostate biopsies are actually doing MRIs of the prostate gland and doing a biopsy that's what we call targeted, based on areas of the prostate gland that look abnormal on a prostate MRI.
So we have a question from Bernard West, who's watching from Dubai in the United Arab Emirates. And he says, is it possible to have low or normal PSA with a dangerously enlarged prostate or with prostate cancer? Maybe I'll add that list. So Sophia, maybe you can address Bernard's question.
Yeah, sure. So yes, so you can have an enlarged prostate and have a lower PSA. And yes, you can actually have prostate cancer there are prostate cancers that just tend to not be PSA producing tumors. And so they actually end up having a very low PSA. So again, that also kind of points to us saying that the digital rectal exam is important, because, if you feel something abnormal, but the patient just happens to have maybe a low PSA producing tumor or a non-PSA producing tumor, which we do see, they're rarer, but we do tend to see them. Then obviously we know that we need to do some further workup to diagnose the patient and make sure that, we get them on the appropriate treatment. But yes, that can absolutely happen.
So I think another, just real quickly, another reason why somebody can have a low PSA and have prostate cancer is if somebody actually has low testosterone and it wasn't diagnosed, for example. So I see that a lot in diabetic men that have a low PSA. because of what we call hypogonadism, which is low testosterone that hadn't been diagnosed. So these are people that if they had a normal level of testosterone might actually have an elevated PSA. So actually their low testosterone was kind of masking their PSA and masking the prostate cancer. Another reason why, the rectal exam is important.
So one, we're going to talk more about low T in a few minutes, so stay tuned for that, guys. But two, I just want to say to people, as an ENT surgeon who has not done a rectal exam for couple of decades now, when you train your finger to do it properly, you actually can feel the difference between a normal prostate, just an enlarged prostate from BPH, and the hardness of a prostate cancer, because many of them are in that posterior lobe of the prostate that's just in front of the rectum. So I actually think it is not at all a violation of your health, and in fact it's an enhancement of your health if your physician is able to do a full exam on you when you come in for your annual. So Ashley said that they take about 12 biopsies, and then we send that off to the pathologist. And then Sophia, you get a Gleason stage. What is a Gleason stage? Why do you have two numbers that add up together? And what is it that we need to understand about this grading system?
Yeah, that's a great question. So basically once you have the biopsy, it gets put onto a slide and it goes to our pathologists. And the pathologists are doctors that look at the cells underneath the microscope. And they basically want to look at the architecture of the cells, or they look at the cells and they want to see how abnormal the cells are from the normal healthy cells. And then that's how they come up with this grading system. The Gleason system was developed by Dr. Gleason many years ago, and it's really stuck, but it's very confusing because actually the lowest number that you can have is Gleason 6, which already sounds scary when you kind of first hear about it. You're saying, oh my gosh, like I already have 6, what happened to 1, 2, 3, and everything else. But it's because of this addition where they kind of add up these two numbers. They kind of look at it and then score what is the majority present in the area that they're looking under, and they give that a particular score. And then what is kind of the minority, or if everything looks at the same, then they give them the two same scores. So you can have like 3 + 3, and that equals 6. But we've actually been moving to a new grading system, which actually starts from at 1 and it goes from 1 through 5. And so the entire cancer community has been shying away from this Gleason scoring system because it's very, very confusing. It can really, as you can imagine, if you're told that you have Gleason 6 disease, and actually that's the best type of disease to be found, they get very, very scared and they get very worried. So we're moving towards this system where it's 1 through 5, and so 1 correlates with Gleason 6, 2 with 3 + 4, and then 3 is 4 + 3, and 4 is 4 + 4. So it kind of it matches together, but that's how we determine the aggressiveness of the pathology.
And then, thank you. I really appreciate that. And I have to tell you, thank heavens that you guys are making it easier, because it is so complicated and unnecessarily so. So unnecessarily either diminishes or increases the anxiety of the patient.
Exactly.
Then you see where the tumor is, right? So Ashley, you talked about identifying it early. So there's 1, 2, 3, and 4 of whether the tumor is limited to one lobe, whether it's filling the prostate, whether it's outside of the prostate, or whether it's reached the lymph node. So can you talk to us about that?
Sure. So when somebody it comes in for prostate cancer screening, we do a biopsy, that biopsy comes back, then we put together a few factors, including the physical exam findings, the PSA result, and that biopsy result. And we categorize the patient as what we call like low, well, very low, low, intermediate, and then there are subsections of intermediate and high risk, right? And then based on those categories, we determine A, what are the best treatment options, and then B, what additional testing they might need. So if somebody is in the high or what we call unfavorable intermediate risk group, we'll do additional screening for signs of cancer outside the prostate, because those are men who are at a higher risk of having cancer that has spread beyond their prostate. So, the typical tests that we do are a CT scan and a bone scan. And then there are newer tests coming out that are actually very exciting. One is called PMSA scanning. I won't go into that, but there's tons of technology. But the point being that if you're very low risk, you're not going to really need those tests because the chance of you having prostate cancer outside of your prostate is extremely low. And then the higher risk people do have those testing. And then if you have sign of, cancer outside your prostate, gosh, this can get so confusing, but if it's widely spread, then generally you're going to go to the medical oncologist. So those are, kind of the classically we think of the doctors that prescribe chemotherapy, and then there can be signs of spread outside the prostate gland, let's say to the local lymph nodes, where you may go ahead with local treatments such as radiation or surgery. So
Yeah, so clear as mud, right? But I think it really
hopefully that makes sense.
It really does help us to understand how physicians think. So Matt Schifrin wrote in and said, let's talk about treatment. And yeah, I think we should talk about treatment. So now we've gotten the staging and we kind of know how extensive the tumor is. And there are different types of treatment that we can talk about. So globally, we can talk about surgery, and we can talk about radiation, and we can talk about observation, because those are sort of the three buckets that people are put in depending on the nature of their prostate cancer and the size of their prostate cancer, and as you said, whether or not it has spread somewhere. So we're going to talk about surgery, but let's talk about radiation first. And I think people know that we use radiation to take x-rays, right, of our bodies, but how do we use, what is radiation therapy, Sophia, and how is it used, and how is it targeted to tumors?
Yeah, no, absolutely. Happy to explain it, because radiation is a big black box that a lot of patients often come and say, oh my gosh, I don't know anything about radiation. And so happy to explain. So basically, yes, that slide tells you how it works. So it works by damaging the DNA within cancer cells, destroys their ability to reproduce. It causes the cells to die. And so the damaged cancer cells are destroyed by radiation, and the body just naturally eliminates them. Normal cells are affected by the radiation, but as you can see, they can repair themselves because they're normal and they're healthy in the way cancer cells can't. So we really harness the ability or the biology, the abnormal biology of cancer cells with the radiation. And so for prostate cancer, just taking a step back. So as you said, the big first choice is, treatment or observation, which we like to call active surveillance. So that's kind of the first division that we think about when we meet a patient with prostate cancer. What are we thinking? What's okay for patients to do? And then if we're thinking localized, like the prostate cancer is localized within the prostate, then we're thinking treatment with either surgery or with radiation therapy. And as I explained how radiation works, there's two forms of radiation therapy that we can do for prostate cancer patients. What I like to call is internal radiation, also known as brachytherapy, which we use two different techniques to actually insert either radioactive seeds into the prostate gland or temporary catheters that deliver radiation. That's a nice graphic there. So we call it low dose rate or seed brachytherapy, where we drop off these radioactive seeds directly into the prostate gland, or the high dose rate, HDR brachytherapy, where we place some temporary catheters the same way. Again, it's actually placed through the skin, which is between the scrotum and the anus. We place these temporary catheters, we bring them down, we do a CAT scan to visualize the catheters, plan their radiation therapy, and then hook them up, deliver the treatment, and we take everything out. So this way it allows us to be very, very conformal in terms of keeping the dose really nice and tight and treating the entire prostate gland with internal radiation techniques. Now, on the other side of the coin is the external radiation therapy, where we use high dose x-rays that go through the body, and we deliver it so that it concentrates directly in the area where we want to treat. In this case, we're talking about the prostate gland. So here's a nice graphic of a machine. We use something called a linear accelerator that delivers these high dose x-rays directly to where we want them to go. And as you can see, these are nice graphics where we outline where the prostate is, and we come up with a plan, and each plan is unique to a different individual's anatomy. So that's why we do a lot of planning that goes into coming up with a treatment course for a patient. and we deliver treatment that way. There are some side effects associated with both types of treatments. They're similar, but basically we cause some urinary bother, which manifests as increased urinary frequency, urgency, etc., some rectal habit changes, and then some minor fatigue. But there's no burning. That's a very common misconception. Patients are worried about their skin. There's no hair loss, nothing like that. But patients generally do very, very well, and we get them through the course of treatment.
So thank you. That was like the best and fastest description of radiation therapy I have ever heard.
I was going to say,
so clear.
I wish I had done a rotation on radiation oncology, because unless you do it full time, I feel like it's the biggest black box even to other healthcare providers. And even in my in my counseling, like I can talk to, even though I don't do the prostatectomy surgery, when they ask about radiation, I tell them what I know from papers, but in terms of actually what happens there, it is hard, and a lot of the reason why, we get them over to the radiation oncologist for counseling is because, of that black box. So right. Yeah, it's great.
Well, and it's really, really important for patients to know that it's not a fight between the surgeon and the radiation oncologist, right? It's a team approach, and it's really keeping the patient in the center so that the patient gets the best type of treatment for their tumor, whether it be active surveillance, which is observation, radiation, or surgery. And that it's not some tussle between the surgeon and the radiation oncologist to sort of get the patient. So, speaking of surgery, Ashley, can you talk to us? People talk about open prostatectomy and robotic prostatectomy. Can you give us a little clue about what the differences are between those?
Sure. And just one other comment on, the treatments not fighting with each other. They also oftentimes, need to work together. So a big use of radiation, for example, is after a man has had the prostate cancer removal surgery, and it looks like, they have, for example, their PSA rising again, or they have really high risk characteristics on their prostate that came out, and it's determined that they need to undergo radiation after their surgery. So, and vice versa, there are men who have a prostate removed after primary radiation. So, these two things not only can be an either or decision, but oftentimes actually come hand in hand in terms of treating our patients. And I definitely, one of the most frequent, groups of other doctors I work with on a continual basis are the radiation oncologists, because we just share patients, instead of, like you're saying, fighting over them. So, yeah. So in terms of the surgery, yeah. So, the typical, there's a lot of misunderstanding because there are a lot of things that can be done to prostates. There are lots of surgeries for benign prostate enlargement, which focus on opening up the channel of the prostate so you can pee easier. Those are not cancer surgeries, right? So one you showed actually was a TURP, where we go in with a camera and we kind of shave the prostate from the inside. A typical thing patients call it is a roto-rooter job. That's not in the prostate cancer bucket. So the mainstay surgically of treatment for prostate cancer is something called radical prostatectomy, which is where you remove the entire prostate and also the capsule around the prostate, as well as the seminal vesicles, which are two glands that insert on the back of the prostate gland. And you actually take that out, and then you take the urethra and sew it to the base of the bladder, because you actually fully detach the two during the surgery. And so the historical way of doing this was through open surgery, where you make a small incision on the lower part of the man's abdomen and you open everything up and you cut out the prostate gland and take it out. The biggest downside with that surgery, and there are absolutely incredible surgeons who do this still, is just that there's a very high blood loss associated with it, even if you do a perfect job. I mean, when I was in residency, I saw this guy do it who was just one of the 4 leaders of the whole, surgery in the whole world, and he, like, there was like a liter of blood that was lost, and he was just like, oh, no big deal. Right. And so with the robotic, they use a surgical robot to essentially do the same surgery, but the main benefit is that when you do a robotic surgery, you actually increase the pressure inside the abdomen by filling it with air, and that reduces the risk of bleeding. And that is the way that the vast majority of prostate cancer surgery is done nowadays.
So the robot doesn't mean that you're in bed, right? It means that you're actually in the operating room And because you use these robotic arms in the surgery, you don't have to do these larger incisions, and maybe you can be a little bit more precise with the tumor removal. Is that right, Ashley?
Yeah, I mean, I'd say that people who do open prostatectomy and are very skilled at it are do it with the same precision. I mean, there's like lots of studies looking at surgical outcomes, open versus robotic, and they're the same. And there can, but I definitely I think there are certain benefits. I mean, it's hard to see in the prostate; it's like deep in the pelvis, and the robotic surgery helps see the whole area very nicely up close. So it is an amazing tool for this surgery, without a doubt.
So we are live on social media, on YouTube, on Facebook, on Twitter, on Shree's LinkedIn page. You can ask us anything if you're watching us live, and we'll do our best to answer your questions. We're carried on WBAI 99.5 FM and on WBAI.org on Mondays from 2 to 3 p.m. Eastern Time. And you can listen at any time on our podcast, and you can certainly watch us anytime on our YouTube channel. We have Amalu and Thiru Iyengar watching from San Jose, California. We have Jackie Justine watching. Neerja Kikeri is watching. We had a question from Nina Yashbe, who is an ENT surgeon in California. She wanted to know what is the correct age to start screening?
Yeah, I mean, well, screening for prostate cancer usually begins, according to the guidelines, at 55. If you have a strong family history of younger prostate cancer in your family, you can definitely screen earlier. For BPH, or urinary symptoms related to benign or non-cancerous enlargement of the prostate, we don't really screen for that. If you have symptoms of frequent urination, etc., then you should just talk to your doctor about it.
Yeah, I think for screening of prostate cancer, it really depends on family history and your age, and also your race, because we do know Black men tend to be more commonly diagnosed with prostate cancer, and then also at a younger age too. So keeping all that in mind is important, and having a thorough discussion with your doctor is also important.
Jack Berajic writes, what urination frequency over an 8-hour period is common once you're over age 50 or 60? So we know people who used to sleep through the night, and now they're getting up maybe once or twice at night to urinate. When is it a problem that they should see somebody for?
Yeah, that's a great question. It's 8,000 different factors that go into that, right? I mean, do you take water pills? Are you drinking a lot of fluid at night? Do you have something like sleep apnea, which makes you wake up and you're sleeping poorly, and you woke up because of your sleep apnea, and then you're going to the bathroom because you woke up? Is it dry in your house? Do you need a humidifier? And because you're not, you don't have your humidifier, drinking too much water at night. And then, of course, there is the reason why somebody's urinating frequently because of their prostate. So, there's no specific number. It's definitely a big detailed evaluation. I'd say if it's getting to the point where it's interfering with your daily activities because you're tired, then you should definitely talk to your doctor about it. I do think, waking up once a night is pretty normal. You don't need to worry about yourself.
And I think if you have BPH or if you don't, what I'm hearing from you guys is that PSA screening once a year is the correct thing to do, no matter what, right? At what age does that start? Is that also 55?
Yeah. So, go ahead.
No, go ahead.
I was going to say, yeah, basically based on the screen, those guidelines, yes. But again, it also depends on family history. So if you had, for example, a father that died of metastatic prostate cancer at a certain age, let your GP know, your general practitioner know, because then you should probably be getting screened at an earlier time. Or again, it depends on race and genetics. And if your family has a long history of breast cancers, perhaps you should definitely let your general practitioner know, and maybe you need to be screened a little bit earlier. So again, it's a conversation, and that's also why the guidelines have changed to basically having an informed decision-making process and discuss this decision of testing for PSA with your doctor.
Thank you. So we have Joe Diamond watching, Divya Hemge watching, Jackie Justine watching, Jeffrey Bumpus watching. Thank you guys so much. Matt wants to follow up a little bit on types of radiation. So what's the difference? We hear commercials all the time, right? For a CyberKnife, for proton beam, for all sorts of radiation types. So how does somebody come to figure out which type of radiation is best for them and their tumor?
Yes, absolutely. That's a great question. And I guess I forgot to mention the most important thing. The reason why we offer all these different options is because surgery and radiation therapy have been found to be equivalent in terms of curing the prostate cancer. So that's another reason why we think it's very important that that patients have the opportunity to chat with both disciplines. Here at Mass General, we actually have all patients diagnosed with prostate cancer meet at the same time, a medical oncologist, a surgeon, and then also a radiation oncologist. So we can talk about all these different options. And if there's something that is steering us to a patient for one way or another way, we'll let them know. But oftentimes the patients are healthy and otherwise, there's nothing else going on. They have equivalent options. And then when it comes to radiation, it gets even more complicated because they have multiple options within radiation. Like I already touched on the internal and the external, but then you touched on some of the additional ones. So within the external beam type of radiation, there are some things called the CyberKnife, which is actually just a machine that specializes in delivering high dose radiation quickly. So in 5 treatments or less typically. We can actually do that with a normal linear accelerator machine, but they just marketed a particular machine to deliver it in that way. And so the 5 dose or 5 treatment radiation technique has actually been something that's being studied extensively. We actually have an open clinical trial here where we're randomizing men to the longer course, which is typically now about 5.5 weeks or 28 treatments versus the 5 treatments, because we're learning now that with our technology, we can really hone in on the prostate and be very, very precise and can see the prostate very clearly and minimize side effects to all those normal tissues. We use something called the spacer, which is actually a rectal a hydrogel that actually pushes the rectum out of the way, because we're so precise within millimeter accuracy. So even with a tiny hydrogel that's just 5 millimeters in size, that makes a huge difference at protecting the rectum. So that's one option. The the 5 treatment course, we're still learning about it. If you have lower type of risk disease, it may be something that you could consider. But if you have a lot of urinary symptoms or you have a couple, unique history with your prostate gland in general, we may not recommend it. And then the proton beam technology is a different type of particle, an external particle that we treat with. It's different than regular X-rays. Basically, the proton beam has been shown to target tumors a little bit more accurately. We can stop the beam a little bit faster than with regular radiation therapy based on the physics of that particle. It's still being investigated in prostate cancer treatments, actually. It hasn't been proven to reduce side effects. That's really what it can do, potentially. We know that the treatments and the cure rates are exactly the same. It's still about 28 treatments, no matter if you get regular X-ray or protons. But the hope is that maybe it can reduce side effects. We actually have a randomized clinical trial going on here and a couple other centers where we're randomizing men to either protons or photons, and we're having patients fill out surveys about their symptoms because we want to know if protons can truly reduce side effects in the short term and long term.
Thank you. That's really very helpful. Let's pivot a little away from cancer, or in the continuum, let's say, of men's health. And let's talk about low testosterone. So, Ashley, you mentioned low T as one of the reasons why maybe your PSA may be low, because you just don't have enough testosterone circulating in your body. And earlier this week, you actually tweeted about type 2 diabetes and sleep apnea and low T. Can you talk to us about what testosterone does and what happens as we age, because it reduces in our body as we age, both for women and particularly for men. Isn't that true?
Yeah, that's true. One of the kind of flashy names for the reduction in testosterone as you age is called andropause. But there's no precipitous drop off in testosterone production the way that women go through menopause, but definitely most men do have some age-related decline. And many symptoms associated with low testosterone can be, low libido, fatigue, decreased muscle mass, decreased ability to lose weight in response to exercise, and I'm sure many of us have heard about that because it's a huge topic. It's also a topic that just has such wild misinformation. So, one of the really most common misconceptions about testosterone is that it is the cause of all erectile dysfunction. And I have so many guys who come to my clinic and they're like, "Hey, doc, I went to this men's health center and they put me on T and my T is normal and I don't know why my penis isn't working." And, that is so common. Now, if you have a super, super low testosterone, you can have erectile dysfunction from low testosterone. But once your testosterone gets to the normal range, giving somebody more testosterone is not going to make their penis work better. That's just, there's like a leveling off, right? So you need to have a normal testosterone to have your penis work. And then if it's not working, it's from some other cause. So typical causes could be cardiovascular disease, so high cholesterol, high blood pressure, diabetes. All of these things actually really affect the penis. And the way to think about it is that an erection is a blood flow event, and things that mess with the blood flow in your body and cause heart attacks, for example, also mess with the blood flow in your penis. And a lot of us in urology basically say that the erections are actually the canary in the coal mine for cardiovascular disease. So definitely, if you're experiencing erectile dysfunction, it is important to talk to your doctor, and get screened with a cholesterol panel, have your blood pressure checked, really, basic things like that, but it's super important. And then another topic that's really important to talk about is the relationship between testosterone and prostate growth and prostate cancer. So a really big misconception is also that testosterone causes prostate cancer. Testosterone does not cause prostate cancer. Suppression of testosterone is a treatment for prostate cancer that has spread outside of your prostate, what we call metastatic disease. And it's also used in combination with certain treatments like radiation therapy, not all the time, but very frequently. But that doesn't mean that it should be used as a prevention strategy. Meaning, some men think that like they can't be on testosterone if they're testosterone low because they're gonna be more likely to get prostate cancer. No, like the way you should address that issue is by having prostate cancer screening when it's appropriate, not by leaving yourself at a low testosterone state. So, those are kind of, I'd say, some key takeaway points about testosterone, but something we could all talk about for probably 100 hours.
Thank you so much.
Yeah.
We have a question from Robert Hillman. Since Black men have a worse prognosis with prostate cancer, is there a different age to start screening them, Sophia?
That's a great question. Actually, it's being discussed right now amongst our field, whether or not we should change the recommendations to have it be more specific with race, ethnicity. Right now, there isn't, in terms of the guidelines, there is no change. But, I think being aware of prostate cancer, being aware of the history in your family, being aware, the fact that you already just said that and asked that question, that's great because you're obviously thinking about that. And so talking to your doctor, asking for a PSA, it's just a blood test just to kind of get a baseline, and that can be followed. Asking for a rectal exam at your yearly visit. I think it doesn't hurt. It's not harmful. It can only be beneficial. So absolutely, talk to your family members about it. It's important.
I want to thank you so much, both of you. This has been just such a jam-packed hour. We are unfortunately at the tail end of this hour. Thank you to our audience for listening and asking questions. Thank you for our male audience for braving the gender barrier and asking questions, which we often don't see in healthcare. I want to thank very specifically Dr. Ashley Winter, who is a urologist at Kaiser Permanente in Portland, Oregon, editor of the Sexual Medicine Reviews Journal, and Dr. Sophia Kamran, radiation oncology at Massachusetts General Hospital, and assistant professor at Harvard Medical School in Boston, Massachusetts. I think we were all treated to incredible, thoughtful, smart, compassionate healthcare ideas from both of our guests today. We want to thank our producers as always. Without them, this show would not work. So thank you guys so much for all that you do behind the scenes before and after the show to make it work. In 2 weeks, we'll be back live with guests Dr. Cheryl Racinos and Dr. Minerva Romero Arenas. Thank you again for watching today. If you like the show, please retweet, like, share, let your friends watch and listen. Bye. Stay safe. Get vaccinated. Get your kids vaccinated.